you have heel pain or recalcitrant heel pain where it never goes away. You've done everything, you know, from icing, stretching, injections, everything that you can try conservatively. And then after 6 months, typically of conservative therapy, if you fail, then I will suggest doing something more advanced, which would mean either a plantar fasciotomy, which is where we cut the actual medial band of the plantar fascia to alleviate the tension on the plantar fascia, or we can do other things like shockwave therapy, PRP, but those things are actually not covered by insurance, and so therefore they make it a little more difficult to attain in most populations. So this is a very good procedure, assuming it's done right. And so what we did today was we set her up, and I already blocked her. And basically I'm going in right around here, right where the plantar skin meets the dorsal skin. There's a little line there you can see. And I'm gonna go in there with an 18 gauge needle and percutaneously cut the plantar fascia, just the medial band. And of course I'm gonna visualize it with the ultrasound as well. You probably can't really see a clear picture because it's too bright in here. But we already know, because I've already established it, and I can see it clearly with my eye. So I can see where it is, and of course when I go in there with the 18 gauge needle, I'm gonna be able to see where I'm cutting as well. Technically, you don't need it. I mean, historically speaking, percutaneous through the skin incision with a blade or a small blade for a plantar fasciotomy has been done for many, many, many years. But we have the equipment, so why not use it and do it right, right? Okay, so that's why we're here, and we're gonna get it done. So I got my little 18 gauge needle here. Get this out, that'd be awesome. There we go. Alrighty. Now I gotta get my bearings again. There's the calcaneus, there's the plantar fascia. Alrighty. Alright, recording? Mm-hmm. Okay, so now we're gonna go in right at that level, and she should not feel any pain. Any pain?
No.
No, good. And I already feel it, and you can kind of see it on the ultrasound already. You can see me moving right, superior to the plantar fascia. See how it's, I don't know if you can see that or not, but I can see it, and I can feel it because it sounds like celery, okay? So you can actually hear it if we're quiet. Hear that? Yeah. And so basically that's what I'm doing. I'm cutting the plantar fascia, slowly but surely. And this one's pretty thick. And the nice thing about our needle is it's not like, it's not huge, okay? So I know I'm not gonna go towards the central band, and plus I can see where I'm at, but I'm not gonna go past where I shouldn't be. The most common complication of this type of procedure is you cut too much, and then you have lateral column instability, lateral column pain. And obviously we don't want that. She had enough pain in her life. This is it. This is all we want. That's feeling much better. And I'm just cutting. It feels pretty good right now. Oh, a little piece right here. So what I'm doing right now is I'm just confirming that I got the plantar fascia, okay? And this is a transverse view, and you can see my 18 gauge syringe going back and forth across the actual medial band of the plantar fascia. And it's getting caught right when I push further, but I believe we got about, what, a centimeter of the band? But you can see as I push further in, I can get more and more of the band. You can hear that click, and you can see the point of the needle, but I don't need to go that far, so I'm not gonna keep cutting. So that's it, we're done. No. Very exciting, but what I wanted to show you in this video is that it's simple, okay? We're talking little tiny blade, little beveled blade, and it's very tiny, very, very, very tiny incisions. So obviously no sutures. The patient recovers very quickly because there's not a lot of dissection. I'm not taking a blunt dissector and going above and below the plantar fascia. I'm right on it. I know anatomy-wise, I know I'm on it because I could see it on the ultrasound. I also confirmed it with palpation as well because you could feel the top and the bottom of the plantar fascia. But it's real simple. So this is an option, but we only utilize it for people with pain that does not go away after conservative therapy. I think American College Foot and Ankle Surgeon guidelines is 6 months of conservative therapy before you consider anything more invasive. So I usually follow that, unless the person has been seeing like 6 doctors and they've been treating over a year, and then I can say the first time they see me, okay, maybe we should do something more aggressive since nothing has worked. in any case, this is an option. It's a nice option. Patient seems pretty comfortable. The injection was, you know, it's a little painful, but we use cold spray to distract her brain so it doesn't hurt so much. And of course, she has no pain during the procedure, so the block works. She's gonna be numb for about 4 to 6 hours. The aftercare of this is pretty much walking in a boot for the next 2 to 4 weeks. In all honesty, I judge it. I have the patient come back in a 1 week, and then if I can get them in a regular shoe in 1 week, I will, because what I don't want is everything to constrict. I don't want anything to scar down. I want it to stay open. I want it to stay separated so that that tension on the medial band of the plantar fascia stays gapped. Because if it reconnects, well, then you're back in the same problem. So weight bearing immediately for me is a thing, assuming they can tolerate it. And she should be able to, because again, minimal dissection, minimal pain. All right, guys? So subscribe to our YouTube channel, subscribe to our Instagram at Healthy Feet Podiatry, at JC